Hello, my name is Peg Nelson. I'm a nurse practitioner at St. Joseph Mercy, Oakland, and it's a privilege for me to be here today to talk to you about some very important information for families that are dealing with serious illness. I call this talk the 3 Sacred Truths about Suffering and how it relates to serious illness. And my premise is really based on the Bible and my Christian perspective. And I hope that it would be helpful to you to just talk a little bit about myself and why I'm here. I'm the director of the Palliative Care and Pain Program at St. Joseph Mercy, Oakland. And I've been a nurse practitioner and a nurse there for over 27 years. I'm a mother, I'm a daughter, I have 3 kids, and I'm a Christian. Just like everyone else, I deal with a lot of ups and downs in life. And one of the things that many of us don't think about, don't deal with, is our end of life. And just like everybody else, I too will be coming to that point, hopefully further down the road, but we don't ever really know. I am here because I and the company I work for, Trinity Health, is dedicated to improving the healthcare as well as reducing the suffering for all of people who are dealing with illness. I see the suffering day to day. We see over 1,000 patients a year at our hospital that are dying or are dealing with serious illness. As a nurse, as a mother, as a daughter, as a Christian, the suffering is often overwhelming. But we realize there's many things we can do. My perspective, and every day when I come to work, I have this prayer over my desk. It's the prayer of Jabez. It comes from the Old Testament. It says, "Oh, that you would bless me indeed and enlarge my territory, that your hand would be with me, and that you would keep me from evil, that I may not cause pain." I look at it, I think about it every day, and I realize that every day I have to think of different ways to reduce suffering. So I hope that this talk will help you understand the suffering that currently exists at end of life, realize what can be done to reduce it, and consider hopefully for you to expand your territory to help others that are dealing with this very difficult subject. And obviously, as a Christian, I want to share the word and the love of Jesus. Dying well is only possible, this is something I say all the time, if everyone gets a chance to live well until they die. It's not a thing that's common to talk about. Most people don't want to die well, they don't want to even deal with dying. But the bottom line is that there's a lot of problems with end-of-life care in the United States. The great philosopher Woody Allen said, "It's not that I'm afraid to die, it's that I don't want to be around when it happens." It's the idea that we in healthcare and we in the United States put off dying over and over again. We don't deal with it. And in Michigan, I'm part of a statewide initiative that has looked at end of life. And we've realized, just like nationally, as it's been studied in other states, that there is a huge issue with end-of-life care not being addressed appropriately, and that the suffering is just overwhelming for some families. In Michigan, over 50% of people die in hospitals. Another 25% die in nursing homes. 75% of people will die in a facility, and most of us never think about that. And one of my initiatives is to look at how do we prepare facilities to deal with end-of-life care. Only 25% die in their home, where most people, if you would ask them, want to die. When they studied end-of-life across the state, they realized that the primary problem in end-of-life was pain. Close to 40% of patients' families reported persistent, severe to excruciating pain over 60 days prior to their death. On this slide, you can see that it doesn't matter where you die, whether it was in the home, nursing home, hospital, even hospice and other areas. There's high incidences of severe pain. And pain is something that can be managed. We do it all the time, every day in the hospital. But for some reason, it's not consistently done across the United States in healthcare. When we interviewed caregivers about the top reasons their loved one's death was not completely peaceful, physical pain was by far the #1 thing people talked about. They also talked about how many people were not prepared. They didn't understand how sick they were. They weren't ready to die. Many were very anxious and depressed. There was unresolved family issues. Symptoms were not controlled other than pain, such as shortness of breath, nausea, agitation, anxiety. And many were alone. It's really something to see in a hospital when you have someone dying and there's nobody sitting next to them. It's a terrible, terrible reflection of how people are dying in the United States today. When they looked at the patients who eventually did get to hospice, which is a very small percentage, only about 25% of patients receive hospice care before they die. Of the ones that got to hospice, close to 90% had no or very poor understanding of their prognosis. They didn't even understand why they were dying. And then the length of stay in hospice is often just days. And actually in Michigan, this time in hospice has declined over the last 3 years. Many people die in nursing homes. Most long-term residents stay until death at a nursing home. 30% die within 1 year of admission. It's very interesting that most people die in hospitals or other facilities. But one of the very important statistics about how people die and how they deal with their serious illness has to do with how often they go to the doctor. In the last 6 months of life, the average person will go to the doctor at least 28 times. They'll spend usually at least 11 days in a hospital and 3 to 4 days in an intensive care unit. And what's interesting, they're going to the doctor over and over and over again, but the pain is still not being treated. The other symptoms are not being managed well, and we're still dealing with people not understanding their illness. So something is wrong here. The bottom line, the quality of how people are dying is that there's physical and spiritual suffering. There's often bankrupted families. Almost 30% of families completely spend all their assets caring for patients and their family at end of life. There's frequent hospitalizations, a high chance of being in the intensive care unit, the family and often the patient not realizing that the patient's even dying, and they don't even understand what their options are regarding treatment. There's a huge burden placed on the family. The physician is often unaware of the preferences of the patient regarding what their treatment should be, as well as the use of resuscitation or aggressive care. And then again, less than 30% utilization of hospice care, which is in the United States set as the gold standard for end-of-life care. So the bottom line is that you have this continuum, we call it, of health and illness. And what happens is you're healthy, and then there's this sort of chaotic period, and then you die. And during that chaotic period where you get diagnosed with a serious illness and you're trying to deal with the symptoms and the burdens of that illness, somehow we in healthcare haven't figured out exactly how to make this a time of peaceful and healing, even though they're coming to end of life. At St. Joseph Mercy Oakland, we started to study, understand, and create services to those with serious illness. And one of the first things we did was started looking at how are people dying. And what's interesting, when someone died in the hospital, we started talking to the family and the staff after that death. And we found over and over again common themes. Shock. Nobody was prepared that this person was that ill. Profound sadness at the loss. Very confused as to why they died. Both the staff and the families didn't really understand what was happening. They were upset with how they died, the physical and emotional and spiritual suffering that was going on. There was a lot of fear of what do we do next? And then obviously because they weren't prepared, there was a lack of closure. When we studied the death experience at a hospital, we started looking at what happens to a patient when they died. Well, number one, if nobody's prepared, often resuscitation is attempted. And certainly pushing on your chest doesn't fix an end-of-life experience, but it does cause a lot of physical trauma. There's a loss of dignity in a hospital. People are put in gowns and often not given much privacy or even understanding of what's happening to them. There's profound pain and physical suffering and loneliness. We were amazed at how many of our patients were alone when they died. This is not only stressful for the patient and fearful, it's also stressful for the staff. Nobody wants to see somebody dying in a room and not have anybody there to love and care for them. There's a lot of fear in a hospital, in a place where they're not familiar, and there's fear about how they're going to die. There's spiritual distress about their end of life and the meaning in their life, and is there a God, and will I get to heaven? All of these things were profound for us as we were studying the death experience. And what was ironic is that when we started talking to patients and families that were just told that they had a terminal illness, the feelings and the causes of the suffering were the same as if they just died. They were shocked. They had no idea. They were profoundly sad. They were very confused as to why this was happening to them and how it was happening to them and what it was doing to them and their body. A lot of fear as it relates to what was going to happen over the next few days to weeks. And there obviously was a lot of suffering for both the patient and the family. What's important to note here is that these causes of suffering that were the same when someone died are different now because we have time. When someone is told they have a terminal illness and they're going through all these terrible things, we have time to intervene now. We have time to make a difference. We have time to help these patients and their families if we make it important in our healthcare. So what do we do? When someone's dying, before the death, if we know they're dying, we need to reduce shock and confusion by preparing them. We need to reduce fear by making sure everyone understands what's happening and there is comfort achieved. And never abandoning our patients and creating systems that support this. Clarifying goals, explaining the burden and benefit of treatment options to prolong life, and making sure that there's spiritual and emotional support for everyone involved in this. During death, if someone is actively dying, those of us in healthcare know that resuscitation isn't going to work. Pushing on someone's chest, as I said earlier, does not cure a terminal illness. CPR and the use of resuscitation was always meant for people who have a chance to survive. Many people don't know that in the hospitals, only about 15% of people survive a resuscitation. On TV, we talk about how we see on TV shows a lot of people survive. And they actually did a study that showed that 75% of people on TV who undergo resuscitation come back alive. But that's really not happens in real life. In real life, when people are actively dying, doing CPR doesn't change that process. But it does make a very traumatic death. If people are focusing on their comfort, we in healthcare need to make sure they're comfortable. And they need to focus on it and be vigilant. And we need to create an environment within facilities, whether it's a hospital or a nursing home, of peace and healing for the patient and the family and the staff. After someone dies, we need to help reduce the shock and confusion by listening, supporting, and setting up grief support. And again, not abandoning people, walking along with families, and helping them during this difficult time. During the dying process, if we can create an environment of peace and healing, and the death goes well, and that people are supported and their comfort is achieved, the grief is so much less complex for families. Having to witness their loved one dying a poor death is traumatic forever for families. So we in the hospital, and we in the nursing homes, and we with hospice have to make sure that we create an environment where we can create peace and healing, and that these families don't witness terrible, traumatic, painful deaths. We need to provide spiritual and emotional support, and we need to follow up. And we realize there is ways to help people with serious illness. The word palliative care is a new word for a lot of people. It's a type of care that is delivered in many hospitals today. The word palliate comes from the French word pallier, which comes from the origin of the word is to cloak or to cover. And when you think about palliating someone, you're really not fixing their problem as much as you're dealing with their symptoms. And we can't cure their disease anymore, but if we're in palliative care, we're focusing on support and symptom management with patients when they have serious illness. Many times it's very hard to decide if this person's going to die or not, but we do know they have a serious illness and they need support and they're dealing with many symptoms at this time. Palliative care is based on the diagnosis of serious illness. It doesn't matter how long they're going to live, but if they have a complex serious illness, palliative care can step in, help them understand what's happening, help them deal with their physical symptoms, their spiritual distress, help them understand their choices about trying to prolong their life. And with palliative care, there's no rules about stopping treatment. It has to do with helping people understand how sick they are and then helping them to decide what their treatment's going to be. And if they're going to try to prolong their life, then the palliative care team will just walk along with them. Certainly, towards the end of someone's life, most palliative care turns into hospice care. Hospice care is a Medicare reimbursed system of care for patients who are ready to say no to life-prolonging therapies. They're ready to say, I don't want to come back to the hospital anymore. I know I have a serious terminal illness, and I'm ready to let nature take its course. Both palliative care teams and hospice teams have multiple people on the team. They have physicians, nurses, doctors, pharmacists,